Hello, my name is Sharon Karlsberg. I'm a principal with ZS Associates and lead for our oncology marketing team at ZS. I'm here today at ASCO 2017 with Dr. Suzanne Topalian. Dr. Topalian is the Associate Director for the Johns Hopkins Bloomberg-Kimmel Institute for Cancer Immunotherapy. And as many of you know, the lead author for the seminal 2012 New England Journal of Medicine article that first detailed the benefits of checkpoint inhibition across multiple tumor types. Dr. Topalian, thank you so much for joining me today.
Thank you, Sharon.
Thinking back on that first publication several years ago at ASCO, in many ways it was transformational of the field of cancer immunotherapy. This year we've seen over 500 individual abstracts published on immunotherapy alone, nearly double what we saw in 2016. With all of the new research coming out, do you believe that immunotherapy and checkpoint inhibition is now standard, should be our new backbone for cancer care?
Well, as you know, it has become standard of care for certain cancers based on evidence that we have so far that there can be benefits in terms of progression-free survival or overall survival, or some of the approvals were early approvals based on objective response rates. But in terms of development of the field, yes, we are now looking at anti-PD-1 and anti-PD-L1 drugs as the backbone to build combination therapies that we think will be more effective than the monotherapy approach.
What's your perspective on the role of CTLA-4 inhibition as the partner for anti-PD-1 therapy?
As you know, anti-CTLA-4 plus anti-PD-1 is the first FDA-approved combination of two immuno-oncology drugs. And it's a very exciting first, but I think there's a lot of room to improve on that combination. CTLA-4 and PD-1 are both checkpoints. They're in the same family of molecules, so they both inhibit immune responses. But they're very different molecules. They have different mechanisms of action. So in that sense, it made there was a rationale to combine them, and we certainly had a lot of laboratory evidence that that combination could be very powerful. But we did find a high incidence of serious side effects, these immune-related side effects. It's more than 50% serious side effects, and many patients have to stop the treatment early on because of that. The overall survival from the randomized trial that led to FDA approval was just reported a few weeks ago at the AACR 2017 annual meeting. And interestingly, the overall survival with the combination was very similar to the overall survival with nivolumab monotherapy. So really the question comes back to, how do we find the patients who are especially going to benefit from that combination, because there is an increased chance of side effects, serious side effects with the combo. And so I don't think that we're there yet. We don't have a biomarker that's going to, find those patients for us. But it's a very active area of research. There are probably also different ways to give that combination that might be less toxic and just as effective, and that's being tested now in clinical trials.
I think there were something over 200 abstracts looking at just checkpoint inhibition in combination with chemotherapy, in combination with IDO inhibitors, in combination with OX40. If we think about anti-CTLA-40 as the first generation in combination with checkpoint inhibition, which do you think are the most promising combination strategies now being evaluated for taking us further, driving for that durable remission with minimum tolerability concerns?
Well, so, we've heard a lot of exciting new information at this meeting about potential combinations. And some of them involve other immune-based drugs, and others involve more traditional therapies, as we mentioned earlier. And among the immune-based drugs, some of them are targeting metabolic pathways, such as the IDO inhibitors. Others are trying to engage other cells in the immune system, such as natural killer cells. Others are targeting additional checkpoints, such as the anti-LAG3. and still others are stimulating immune cells through positive receptors such as anti-GITR. So it's a very, very complex landscape, and it's going to be interesting to see which of these ideas will rise to the top. Of course, it has to be evidence-based. I expect when we return here next year in 2018, we'll be a lot further along in learning about these things.